Good afternoon. It is a pleasure to be back up again, and I want to talk to you today again about differentiated thyroid cancer, this time discussing thyroglobulin positive patients who have a negative diagnostic whole body scan, or the iodine refractory patients. So we're going to do this again in a case-based format and review a few minor or major points along the way. So you've seen my disclosures. So we'll start with our case. This is a 55-year-old female. She had a total thyroidectomy. She had a 2.5 centimeter papillary thyroid cancer, classic variant, no extrathyroidal extension. Vascular invasion was not mentioned on the pathology report, and no lymph nodes were removed. So this is an NX tumor. So since it's afternoon, I want to keep you awake. How many people would give her radioactive iodine? Show of hands, if you would give her a radioiodine. No one? Okay, it's a good. So this looks like a fairly low risk case. So the current ATA guidelines are giving us a little more guidance on the administration of radioactive iodine. And in our patient, she has a tumor size of 1 to 4 centimeters. So the body of evidence would suggest that radioiodine does not improve her disease-specific survival. And there's conflicting or observational data that radioiodine would improve her disease-free survival. So routine radioiodine is not necessarily recommended, but it may be administered in certain cases, particularly if the patient has an aggressive histology or if there's vascular invasion. So if I saw this patient today, this is an older case, then I would be calling the pathologist and asking them to assess whether there's vascular invasion, if there's any evidence of microscopic extrathyroidal extension, just to get more information, because we know that this vascular invasion, especially the number of vessels involved, does impact the recurrence risk of this tumor, and it may make me decide to give radioiodine. And also, based on her age, we know that age over 45 has a higher risk of recurrence, so this might, if their pathology review says there is vascular invasion, because of her age, I might be more inclined to administer radioiodine. But at first glance, I would be inclined to say she does not need radioactive iodine. Well, this was a case from a while ago. So she did give radioiodine. So this was before we started moving away from giving so much radioactive iodine. She was withdrawn from thyroid hormone, and her thyroglobulin stimulated to 5.2. We did not have a diagnostic whole body scan prior to the treatment, but we did administer a treatment dose of radioiodine with 125 millicuries, and you can see the post-treatment scan shows a little bit of uptake in the midline, suggestive of a thyroglossal remnant. There was no evidence of distant disease. So 6 months later, she comes back to clinic, and her suppressed thyroglobulin is undetectable, but she has newly positive thyroglobulin antibodies. So looking at her over time, you can see she initially had negative antibodies before she got radioiodine, and then after radioiodine, her antibodies became positive, but it's a different assay than the previous two. You can't necessarily tell that from this, but I'll just tell you that this is a different thyroglobulin assay. When we recheck it with a different assay, you can see her antibodies are negative after that initial positive antibody titer. So she is a year out from her radioiodine therapy. She looks like she's free of disease with this potential bump in her antibodies. It's not clear if that is real or not. But she has a withdrawal scan, and again, her thyroglobulin is negative, but her antibodies are positive with that different assay, and they're higher than the previous value. But her whole body scan is negative. So looking again, going back between the two different assays, you can see that she's antibody negative clearly with one assay, but the other one, her antibodies are not only positive, but they're trending up. and her diagnostic whole body scan was negative. So the question is, what is the next step? Before we address that, I want to kind of talk about this antibody positivity thing. We've kind of touched on it a little bit in other sessions. This is a complicated graph, so I want to walk you through what it means. So these are 4 different thyroglobulin assays. This first assay here is Carol Spencer's thyroglobulin assay by radioimmunometric assay, so RIA. So this is considered to be the gold standard for this particular study. She took 143 samples that were known to be antibody positive. Then she ran the samples in these 3 other assays to determine how often these were antibody positive with the other assays. So with her test, all 143 were antibody positive. And then she ran it with the other 3 tests. The black bar represents the analytic sensitivity. The white portion of that bar represents the manufacturer's cutoff. So that number that we were talking about earlier, the less than 4, the less than 100, whatever that number is that is reported by your lab, that is the difference here of what is detectable, but it's not being reported, okay? So what you can see with each of these 3 different assays, and these are the names in the US of the various assays that we're using, and it doesn't really matter what these are, it's rather just to point out that we see a lot of variability in the ability to detect antibodies. So in this Roche assay, in number 2, you can see that 44% of the samples, 44% of the 143 antibody positive samples were read as negative. They were false negatives. They did not have antibodies detected. And then 35 with the Beckman and 62% with the Siemens Quest. And what she pointed out with this is you can see that if we use the analytic sensitivity, if we actually gave a measurement as low as it could detect with the assay number 2, it would have caught all of the antibody positivity, whereas 44% are read as negative even though they really are detectable. So that cutoff that is used with autoimmunity, if we removed that and used the actual analytic sensitivity, we would have been able to detect that those patients were antibody positive. So whether or not the patient's antibody positive isn't so important. It is important, but more important is what is the trend. So we saw in our patient that her antibody trend was going up. So of course that is concerning as we use that for a surrogate marker for disease persistence or recurrence. But if we have an antibody titer that is declining, what does that mean for the patient's risk of recurrent disease, or an antibody titer that is stable? So this is just a compilation of numerous studies, and they took patients who were antibody positive, and they broke them down based on what the trend in their thyroglobulin was. So 75% of patients were antibody positive, but showed a declining trend in their thyroglobulin. 35% had a greater than 50% drop in their thyroglobulin. When they saw that, there was less than 3% of patients who had recurrent disease. When they had patients who had a stable thyroglobulin, 18% of the patients in this study had stable thyroglobulin values. They found that about 20% had persistent disease. And they also found in this study that the relationship with antibody positivity was inversely correlated, such that if you had a higher antibody titer, you had a lower likelihood of ever getting a negative antibody value. And then those patients who had a greater than 50% rise, there were 7% of patients who had a 50% rise. 40% of those patients eventually presented with recurrent disease. So again, this idea that the trend really does matter, and you can see that the median time for disappearance of the antibodies was about 4 years. The other point that they've identified in this study was that antibodies can become positive initially after radioiodine therapy, and for about 8 months after radioiodine therapy, those antibodies can kind of go up and then come back down. So with our patient, she did come up after radioiodine, but she continued to go up when we changed the antibody assay and we determined that she has a rising antibody titer. So in her case, we ordered a CT scan of the chest, which showed multiple bilateral pulmonary metastases, or nodules, that looked suspicious for metastases. She had one in the right upper lobe of the the right lower lobe of the lung that measured 8 millimeters. And so this is her little nodule here in the lung. And we continue to follow her with serial thyroglobulin antibody measurements, and she had a PET CT done at another hospital. And since the patient had the scan, of course, I'm going to use that data. And fortunately, the PET scan showed no FDG activity in that lung nodule. They saw no other evidence of distant disease in her. She had an ultrasound that showed no abnormal lymph nodes on ultrasound. So what do we do now? So looking at PET positivity, a negative PET scan is informative. So even though it's negative and you're trying to find out where this is all coming from, and in her case, we suspect it's these lung nodules, but we can get information from the fact that that PET scan was negative. And so we know that from the study in Memorial Sloan Kettering, when they follow these patients, nearly 400 patients with thyroid cancer, they stratified them based on whether the PET scan was positive or negative. There was a statistically significant difference in survival in those patients who had a negative PET scan compared to those who were positive. Now, ultimately, they identified disease in about 33%, 34% of the FDG negative patients by some other imaging modality, whether it ultrasound or CT or MRI. But only 2 patients in the FDG negative group died from their thyroid cancer. So this is very important prognostically speaking. 10-year survival is excellent if they have a negative PET scan. So it makes you, the clinician, reassured, and it makes the patient reassured if we tell them what this means. So she then has a withdrawal scan, and she has a thyroglobulin that is still elevated, but now, her thyroglobulin antibody is still rising, but her thyroglobulin is positive. So we do a diagnostic whole body scan, which is negative, and we give her an empiric dose of radioactive iodine. Now, bear in mind, when this was done was several years ago, so I would not necessarily advocate giving empiric radioiodine now, but this is what happened with this patient, and I want to show you her course over time. So she had an FDG PET that was negative, and a diagnostic and a post-treatment whole body scan that were negative. So what does that mean for her prognostically? Well, you can see that survival is excellent in these patients who have RAI negative disease. Even though the post-treatment scan was negative, that still is actually a good prognosis for her. And in this study, they found that having a positive post-treatment scan had a negative impact on prognosis in these patients. So we get frustrated thinking, oh, I'm not finding out where this disease is, or I'm not adequately treating it. But if you look at this data, you can reassure yourself and your patient that this actually is a good thing for the patient's survival. So following her after her treatment, her empiric radioiodine, you can see here, 6 months later, her thyroglobulin antibody is still rising. So we repeat her CAT scan. And she has several new but small nodules in her lungs. So these are probably around 5 or 6 millimeters. And a subtle increase in the size of the 8 millimeter nodule to a centimeter. So the question then is, does she need additional therapy? Her antibody titers are rising. She has new nodules appearing in the lungs. The radioiodine didn't work because she's having this progression of her disease. So do we need to give her a systemic therapy to stop the progression of her cancer? So bear in mind, this was 5 years ago. First of all, before we go to what we did for her, what is the definition of iodine refractory disease? And this is something that we debate a lot about. What does it mean? Did it work? Does it not work? How do we know? So this is from the ATA guidelines. And so the there's 4 different definitions for iodine refractory disease. So one, obviously, if the malignant disease never takes up the iodine, then it's iodine refractory. If some tumor tissue takes up iodine but then loses its ability to concentrate radioiodine, and in the absence of the patient not having a good preparation for the scan, so they're not iodine contaminated, they didn't have a big CT scan prior to the radioiodine, you feel confident that they observed the low iodine diet. In that case, if the tumor loses its ability to concentrate iodine, then it is considered iodine refractory. And this can potentially occur if a tumor dedifferentiates, becomes poorly differentiated. If radioiodine is concentrated in some lesions but not in others, then there's really no benefit to giving radioiodine because those lesions that don't concentrate it are probably not going to respond to it, so they're going to progress, and then the few lesions that do take up the iodine, it's not really going to help them in the overall picture. So that's considered to be radioiodine refractory. And then if the patient has metastatic disease that progresses despite adequate preparation for and concentration of radioiodine. So a patient who has rising thyroglobulin, as in our case, or they have new lesions that are appearing, or if the lesions that were there before are getting bigger. So this is when we were doing the sorafenib trial. So the decision trial was available for her to enter. So a multi-center randomized control trial looking at patients with iodine refractory progressive disease over 14 months prior to entry into the study. They needed a tumor larger than a centimeter, and they were randomized 1-to-1 to placebo or sorafenib. And so you've probably seen this data, but the sorafenib was shown to improve progression-free survival. So the median time to progression was 10 months, almost 11 months in the sorafenib arm, and it was about 6 months in the placebo arm. It's important to note that about 70% of the patients who started on placebo crossed arms and went into the sorafenib arm and received treatment. They were unblinded. So there were significant adverse effects with this drug. So 76% of patients had a significant hand-foot skin reaction. Diarrhea was common, and hair loss was also very common. So she was enrolled in the decision trial in 2010, and she was assigned to the placebo group. So as we follow her, you can see when we now measure her thyroglobulin by RAA with Carol Spencer's lab, her thyroglobulin is detectable and rising, and her antibody titer is continuing to rise. But when we follow up with the CT scan of the chest 6 years after her initial scan, what we can see is that the largest lesion in the right lower lobe here has increased in size from 8 millimeters to 13 millimeters. So not a dramatic amount of change, 5 millimeters of growth over 6 years. So that's what I would consider to be a slowly progressive tumor. And the number of nodules she has in her lungs is what I would consider to be a low tumor burden. So fortunately for her, she didn't get the drug, and she got the placebo, because this is somebody that we're currently following, and we're not putting them on a drug. So we're learning a lot as we're running these trials and understanding better this tumor biology. But this is a very difficult decision that we all struggle with every day in clinic, and we have tumor boards to help us decide when should we treat these patients, when should we watch them. And this is definitely somebody that I would do active surveillance. It's not do nothing, but we're actively watching them, and then we're deciding when to pull that trigger on treatment for this patient. So this low volume of disease can smolder along for many, many years, as we've seen with her, but effectively, we haven't done her any harm because she's not symptomatic. So just as take-home messages on this particular case, the new appearance or increasing level of thyroglobulin antibodies is suggestive of recurrent disease or progression of disease. The thyroglobulin and the thyroglobulin antibody should always be measured by the same methodology. The slow progression of the tumor when it's FDG negative still is a marker of good prognosis, even if it's not avid for iodine uptake. And this, again, as I said, is a challenge to know when we should intervene on these patients. And I think we're getting better at it. The new guidelines are doing a better job of helping us with this, but it's still something that I have a discussion with my oncologist. Is this patient ready for you to see her, or do you want me to wait and sit on her for another couple of months? So our next case is a 21-year-old woman who had a total thyroidectomy and central neck dissection. She had a 2-centimeter papillary with unencapsulated, and it had extensive vascular and lymphatic invasion. The left lobe also had some microcarcinoma within it. 5 of 7 nodes were positive for metastatic disease, and there was extranodal extension. So I think we would all agree this is a higher risk patient, somebody whom would benefit from radioiodine therapy. But she's pretty young, so very concerning in that aspect. Thyroid hormone withdrawal for her radioiodine, we don't have any labs. She was treated with 102 millicuries of I-131, and her post-treatment scan showed 1 focus within the thyroid bed. 6 months after her RAI, her thyroglobulin was still elevated at 4. CT chest was negative, CT neck was negative, and she had no enlarged lymph nodes on CT. 9 months after her radioiodine, she has a recombinant human TSH stimulated diagnostic whole body scan. She stimulates to 24, but the scan is negative. So what's the next step? Should we give this patient empiric radioiodine therapy? So when we look at empiric therapy, this is something that we used to do a lot of, and we're now getting away from doing this as much. And the reason is these studies that I'm going to show you. So before we were using standardized imaging with CT scan, ultrasound, and MRI, we would use the diagnostic whole body scan and the post-treatment scan to give us direction as to where the tumor is. And when we look at this study, it's an older study, but 60 patients, 28 were given empiric radioiodine therapy and 32 were observed. What they found is that only 43% of the time did the post-treatment scan localize the disease for the physicians. And so this did not improve the ability to identify the tumors in the majority of patients. When we look at more recent studies that are using comprehensive imaging to help direct us as to where the tumor is, with CT scans and ultrasound and MRI and PET, you can see these 2 more recent studies looked at patients who had a stimulated thyroglobulin of either greater than 2, negative imaging, or a thyroglobulin greater than 10, and you can see the number of post-treatment whole body scans that were negative was very high. So most of these patients, we didn't identify where the disease was. And when we take the data from Kim, after that high-dose therapy, and we stratify those patients as to whether or not they had an improvement in their disease-free survival, you can see there was no statistically significant difference in those folks who received radioiodine therapy empirically versus those who were observed in terms of their disease-free survival. And furthermore, there was no improvement in the thyroglobulin lowering in those patients. There was no significant difference between the 2 groups in terms of the number of people who had a reduction of 50% or more in their thyroglobulin. So showing us that empiric radioiodine really doesn't help for the majority of patients. Now, we don't recommend radioiodine in this patient. She gets referred in and gets an ultrasound of her neck, and there shows multiple abnormal lymph nodes. And if you remember to the beginning, she had many nodes that were positive, 5 positive out of 7. So when I see numbers like that, it makes me very concerned that there's a 6th, a 7th, and an 8th node involved. If she had 5 out of 20 or 5 out of 25, I would think that was a more complete dissection. So she has a neck dissection and has multiple nodes that are positive, as you can see here. And when we look at her 6-month post-op labs, you can see a significant drop in her thyroglobulin. So should we give her a dose of radioiodine after surgery? So this is looking at adjuvant radioiodine therapy. So this is 45 patients who had a stimulated thyroglobulin greater than 2 after a neck reoperation for local regional disease. And none of these patients had distant mets. And what you can see is there was no difference in recurrence-free survival between those folks who did not receive radioiodine and those folks who did. And when we look at the thyroglobulin, there was no significant difference in terms of the drop in thyroglobulin, whether they received radioiodine or not. So we're currently not giving routine radioiodine therapy after a reoperation. Rather, I explained to the patients, we're just going to see how we did with the surgery. Let's follow you over time. Now that the bulky disease is removed, let's continue to watch you. So as we follow her thyroglobulin stimulates to 5.3. So what does that mean for her? That's a pretty high thyroglobulin. When we look at this retrospective study of patients who have had a thyroidectomy and an initial radioiodine, what is their stimulated thyroglobulin at year 1? If it's greater than 2, if it's between 2 and 5, 5 to 20, and greater than 20. And what are the odds of those patients becoming undetectable or less than 1 with stimulation? And you can see that a good number of patients who stimulate to between 2 and 5, 41% within almost 6 years had an undetectable thyroglobulin with no further therapy. Those between 5 and 20, 17% had an undetectable thyroglobulin within 8 years. And then one patient who had a stimulated thyroglobulin greater than 20 became undetectable. So somewhere between 5 and 20 stimulated thyroglobulin, many of those patients, if we simply observe them, may become undetectable with no further therapy. So we follow our patient. After her stimulation, her thyroglobulin drops from 1 to 1.1. This is her initial post-op value. And then you can see a steady decline in her thyroglobulin values over time. So in this patient, she's young, she's responding well to therapy. We'll continue to follow her with ultrasound and make sure that we're not missing any additional nodes in her neck. And as long as her thyroglobulins are falling or are stable, we'll continue to observe. So the take-home messages here, ultrasound should be our first-line imaging. If we've got a differentiated papillary thyroid cancer, follicular less so, but certainly with papillary tumors, we should be doing ultrasound as our first-line imaging modality. And the current recommendations are to do an ultrasound 6 to 12 months after surgery and or radioiodine. And the reason for that is that the vast majority of patients who have recurrent or residual disease, it's going to be in the neck, especially in a 21-year-old. There's no role for routine empiric radioiodine therapy if comprehensive imaging is negative. So if you've done CT and ultrasound and you can't find the disease, then that's probably not that bad of a tumor, that it's not going to kill that patient. So why am I chasing down that number? Rather, I need to follow that patient over time. I need to continue to do ultrasound and see if a node shows up. I need to continue to follow the calcitonin or CT scans if the thyroglobulin is rising. And eventually you'll find the tumor. But giving empiric radioiodine to try to identify that tumor, it's a much less sensitive test than is a CT or an ultrasound, so I don't think it's useful, and we're exposing our patient to radiation. There's no benefit of adjuvant radioiodine therapy after re-op for local regional disease if imaging is negative. So if we don't see pulmonary metastases, then we can simply follow these patients post-operatively. And if their thyroglobulins are declining, then we do nothing except continue to watch. If the thyroglobulin rises, then that's a different story. It may be reasonable to consider radioiodine therapy in that case. And it's important to remember that thyroglobulin levels can decline over time, even with us doing nothing. So why that is not always clear, but perhaps it's the immune system keeping the disease in check, or the radioiodine has a delayed effect. In any case, as long as it's declining, that's clearly a sign that this tumor is responding well, and we should be happy with that. So with that, I will finish. I thank you. I'm not going to be able to stay for questions, so I apologize for that. I have a flight to catch back to the States, so I apologize, but I want to thank you all for your hospitality. It has truly been a pleasure and a privilege to be here. Thank you.